So good afternoon, and thank you for being here. My name is Nitesh Sood. I'm a cardiac electrophysiologist at South Coast Health in Massachusetts. And I am here to talk about an interesting conversation about pulse field ablation and the role of hybrid or convergent surgical ablation in the realm of where we stand with pulse field ablation. So without further ado, let's get going. I think it's a very provocative conversation with posterior wall becoming such a focus of what we do with pulse field ablation. But just as a quick backup, persistent and long-standing persistent atrial fibrillation still constitutes a fairly big population of patients we see. May not necessarily be every practice, but if you look at the actual numbers, majority of the patients we see are actually in the persistent category. And interestingly speaking, almost half of them are long-standing persistence. Depending on, again, I think the pattern of practices, we may not see all these long-standing persistence, but these patients are certainly out there. So again, 45% patients that we see or that are out there are long-standing persistent atrial fibrillation. As far as posterior wall is concerned, I would say in the pre-pulse field ablation era, there's been mixed data. There's data that posterior wall ablation does help, especially the Converge study that was done with the hybrid ablation showed that benefit. Kapla sub-study showed that benefit. But since then, there's been some studies that show maybe there's not so much benefit. One of the big issues has been the very, very high reconnection rates in redo procedures when we attempted posterior wall ablation. So what is the data on pulse field ablation? Before we go there, this is the current sort of paradigm of what we are looking at in the EP world. We are looking at posterior wall ablation or PFA for persistent atrial fibrillation, long-standing persistent atrial fibrillation. But again, as you see, most of the clinical studies, as you see in the center tab, are still focused on that persistent subgroup. I would argue that if you had patient who had less than a year, which is where the persistent group is, I would not entertain surgical ablation in those patients unless they've failed multiple previous attempts or are resistant to therapy in the past. But the long-standing persistent, those patients are still a very small subset of what we are doing or studying in clinical studies. So have we looked at this with pulse field ablation? And most of this data comes from Europe, and I'll show you a couple of really nice, interesting studies. The first one, of course, is Dr. Reddy's study looking at the Manifest registry, which is the largest registry. They went back retrospectively, looked at their patients who were persistent, so about 550 patients, and about 24% of those underwent posterior wall ablation along with PVI. And as you can see on the Kaplan-Meier curves on the right, there was no real difference, and about a 70% outcome at a year or so. It's not terrible, but again, no addition or benefit of adding posterior wall ablation to pulmonary vein isolation in patients with persistent AFib. Retrospective study, initial experience, we didn't have eyes contact and so on and so forth that we have now. So what about more recent data? Another very nice study done and published a couple of years ago, where prospectively this was looked at. So this, I think, is a nice study, and I'll spend a couple of minutes on this slide. So the first question is the duration. And these patients were about 26 months average duration. So I would argue these are real persistent, even long-standing persistent patients. They divided these prospectively with a pentastline catheter into PVI versus PVI posterior wall. And at the end of 1 year, the outcome was not encouraging. For these patients with long-standing persistent AFib, we are back to that 50% zone, the same range we've had with radiofrequency, with cryoablation, with vein of Marshall in the Venus study. No matter what study you looked at, we sort of, on the endocardial side, being consistent about that 50%. And same thing was shown with PFA. But why? I always question, why is there no benefit of posterior wall ablation in these patients? Well, there are two or three options. First one is that, well, PFA doesn't work, and there's a lot of reconnection on the posterior wall. Second is posterior wall may not have much to do with uh, a persistent atrial fibrillation. But we do know that there's epicardial connections, there's epicardial endocardial dysynchrony. So how do we get to the bottom of this? The one nice thing I like about this study is they did a bunch of redo procedures on patients who had recurrences. So out of their patients who had recurrences, about a third or more underwent a redo procedure. And what they found in their redo procedures was, as you see on the right side over there, in the redo procedures, N of 26, that 85% or majority of these patients actually had durable posterior wall isolation, but they still had recurrence. So despite PVI posterior wall and reasonably healthy voltage, as you can see on the other side, these patients still had recurrence of persistent atrial fibrillation. Some patients actually had an atrial tach coming from the roof area where you would assume the septopulmonary bundle would be. And a very minority of patients, about only 15%, actually had reconnection of the posterior wall. So we can say that we can get good endocardial posterior wall isolation with pulse field ablation the way it stands today. But we are still not seeing clinical benefit at all in patients who have persistent atrial fibrillation or long-standing persistent atrial fibrillation. And of course, there's an editorial here that sort of talks about, does it really work? And there's a lot of chatter now. Are we really vaporizing the posterior wall because it's easy to do, or because there's actual clinical benefit? Another very recent study from Dr. Natali and group looked at non-pulmonary vein or non sort of PVI posterior wall triggers. And as you can see in these three graphs, they looked at coronary sinus isolation, left atrial appendage isolation, and mitral isthmus ablation. That's the blue. Acutely, they did a great job with all three. Then they gave adenosine, which is the orange bar, and looked at dormant conduction. And again, they reablated if there was dormant conduction. All these patients came back at 3 months for a left atrial appendage occlusion device. And what they found was that the persistence of block across mitral isthmus was 5%, appendage was 4%, and CS was 1%. So there's a huge drop off at 3 months for non-pulmonary vein triggers with pulse field ablation. So why is that? Again, sort of begets the question, what are we doing that's not right? And why are we not seeing clinical benefit? This then takes us to this data that we have known for a while, is that there is endocardial epicardial dysynchrony. On the left, you see a case where endocardial PVI posterior was done by Dr. Tung and colleagues. And in the same case, after ensuring there was endocardial PVI posterior wall isolation, they got epicardial access and put the Orion catheter in the epicardial space. And as you can see on the bottom on the left side, that patient's posterior wall is still in atrial fibrillation, while endocardially there is clearly posterior wall isolation. Similarly, shown that there is epicardial pulmonary vein reconnections that are seen on the epicardial map compared to the endocardial map, even though there is isolation. And that has been one argument that people have brought about for doing posterior wall isolation in everybody, that there can be epicardial pulmonary vein reconnections. So this epi-endodysynchrony concept still exists. How do we figure out if it exists in the day and age of pulse field ablation? So I would like to present two cases that I have done recently, which I think help they're at least thought provoking, and they help elucidate that there may be something more to this story than just doing an endocardial isolation. So this is a patient of mine who initially had a cryo PVI in 23, had recurrent AFib. I took her back for pulse field ablation, persistent AFib for 7 months. The veins were isolated, there was fractionation, so she had roof and posterior wall isolation done, had early recurrence despite amiodarone, and hence she was scheduled for a convergent ablation. So I'm going to show you first the map from my redo procedure. So this is after the cryo on the second procedure I did. You can see there's significant fractionation across the posterior wall. The veins are isolated. She underwent PVI posterior wall isolation with pulse field ablation. And as you can see on the post-grid map, she had very nice post-wall isolation. These are the lesions we did just based on contact. We use interior projection of 2 millimeters. So we try to really ensure that there is contact. In the following slides, I will show you a couple of surgical videos of the convergent ablation, and I'll also show you epicardial maps. What I want you to notice, and I know we are not used to looking at these surgical videos, but what I want you to notice is the questions I had in mind when I was sort of going to the OR to help the surgeon map is, what does the posterior wall look like after I have done endocardial pulse field ablation? Do you see scar? Do you see adhesions? Do you see, some sense of transmurality? Anything? And what you will see in the following video is that you can actually see cryo lesions. You'll see a white crescent-like area near the veins, near the antrum, where the cryo balloon must have sat. But the posterior wall looks pristinely healthy. It looks nice in pink tissue, which suggests to me that whatever I did endocardially did not translate to epicardial changes. So here is the here's the surgical video. So we'll play that for you. And as you see here to the left of the screen, you will see that there is a sort of white crescent-like area that suggests cryoablation. I'm going to pause this for a second to sort of point it out to you right here. Right there, you see an area that shows where the cryo balloon was. And as you turn around, the surgeon is looking sort of upside down view to the posterior wall. There is no real ablation that can be seen on the epicardial side. So this patient right here is the mid-posterior wall. As we go along, on the left, you see some white areas where the cryoballoon is. But there is no real sense that there was any epicardial translation of posterior wall ablation that was done from the endocardial side. We'll let this sort of play. We use the HD grid, as you will see in the next view as coming along, and we use the HD grid to map because, of course, just looking at tissue is not enough. But convergent ablation is done now with epicardial mapping at most centers, and it's actually pretty darn good. Doesn't really add a whole lot. You can see again the white area on the left of the screen is where the cryo lesion was. This is the surgeon in real time, unedited videos as how long it takes him to or her to map for the epicardial portion. You have to always inject some fluid to avoid electrical noise. And the epicardial map, which is next here, shows this. So as you see on the epicardial map with the grid on this patient who'd had previous posterior wall ablation and PVI, there are significantly preserved signal. The same sort of stuff I would argue that you saw on the map I showed you on the redo procedure. This is post-ablation. We always check post-ablation. Again, doesn't add more than 5 minutes or so. And this is just a surgical lesion set. For people who have not seen this, they are pretty prominent. And you can now see with the post-mapping of the grid that this patient has now had epicardial posterior wall ablation along with endocardial posterior wall ablation. Again, real-time unedited videos of how long it takes to do a grid map. And as you will see, it sort of turns around and you can see nice posterior wall ablation from end to end over there. It's quite dramatic. If you haven't seen the surgical ablation on the posterior wall, it's very, very obvious what's being done. And this is now the endocardial map of the same patient. So I guess one argument here could be that we don't really know. We don't really know because I did not map the endocardial posterior wall prior to the surgical procedure. It is very much plausible that my pulse field ablation lesions were just stunning. It is very plausible that if I had gone in to do an endocardial map prior to the surgical procedure, I may have found a full reconnection of the posterior wall. I completely agree. But again, you would expect at least some ablation. You would expect some signs of posterior wall ablation. In this case, the tissue was completely preserved. So can you really argue or justify that we really had endoepidysynchrony? Based on this case, I would say it's thought-provoking, but it's not. I don't think there is proof because there certainly could have been endocardial, posterior wall reconnection after my pulse field ablation. So then I'd like to show you a different case to see if we can answer that question. So this is a patient who was actually part of the FDA ID study. So he had pulse field ablation a few years ago as the first go around, persistent AFib. He had PVI posterior wall, and then did okay for 3 years. Had recurrence in 2024, and I did a redo procedure again with pulse field ablation in 2024. I had immediate recurrence and tried drugs, tried cardioversion, but again had recurrence and hence had a hybrid ablation. So now this patient has had 2 attempts at pulse field ablation and then a hybrid procedure. So the next slide is a map for my first redo procedure. So this is the 2024 ablation after he had already had PVI posterior wall in 2021. So what you see here is that the posterior wall and the right veins actually look pretty darn good. There's a reconnection of the left veins, as you can see here in electrograms, but the posterior wall looks, like it's still isolated. And this is on a grid map. This is our lesion set. So we used, I did a few roof lesions. I did some carina lesions on the right, certainly took care of the left veins. And on the, you can see the post map with the grid. So you can see that patient still has posterior wall isolation like he did after my first ablation and now has full PVI as well. This is now this patient's epicardial map. What you see, just to give you some orientation, is this looking from the back, and it's the right upper vein, the right lower vein, the left lower, and the left upper. So you can see that based on the epicardial map, for this patient, we cardioverted the patient prior to the surgical portion because I really wanted to see what's going on. And even though there is some isolation of the posterior wall, but there are these patches of healthy tissue. I mean, this is sort of, mid upper left posterior wall here where the arrows are pointed. Same thing on the right side and same thing on the bottom. Patient actually went into this atrial flutter / tachycardia during mapping, and you can see here. So, right side, left side, and I would say mid to lower posterior wall, this patient had continued preserved voltage, and not just preserved, but quite healthy voltage. So it was a very patchy job, even though I had endocardially already demonstrated that there's good persistent posterior wall isolation. This is this patient's map of post-surgical ablation. Now you can see nice posterior wall isolation surgically as well. Again, just the lower portion of the posterior wall. So to conclude, based on these 2 cases and what we have seen with the data on pulse field ablation in long-standing persistent atrial fibrillation, it certainly is a safe and effective modality. We are all doing it efficiently and safely. There is no question about it. However, there is really no evidence as of today that posterior wall beyond PVI adds clinical benefit. And I think this is the argument that we are all seeing on social media, in data, that are we really vaporizing the posterior wall with no additional benefit? And the counter argument is, well, maybe we are taking care of epicardial pulmonary vein connections. Maybe we are doing better and better job as we are going along with better contact assessment and of pulse field ablation. However, especially for non-vein triggers, certainly the data is quite humbling. Less than 5% mitral isthmus and appendage isolation is very humbling. So, for people who are doing concomitant procedures, which I know I am as well, and we are isolating the appendage endocardially with pulse field ablation, rather than doing an epicardial procedure like a lariat or an epicardial clip, These patients have 95% chance of left atrial appendage reconnection. And once you put a watchman or an amulet in there as part of a concomitant procedure, there is no real other way to isolate this appendage anymore because you have the endocardial device. And just to conclude, epicardial endocardial dyssynchrony, as I showed you in these two cases, still plays a role. And I would argue, is this the reason why we are not seeing clinical benefit of pulse field ablation for posterior wall ablation, even though surgical data and Converge has traditionally shown that there is benefit of addressing the posterior wall epicardium. So with that, I would like to conclude. Thank you so much for joining me for this ViewMedi presentation. I would like to thank the sponsors and ViewMedi for allowing me to publish and talk about these two beautiful, interesting cases. And I'd be happy to take any questions from the audience if there are any. Thank you.